Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hey guys, it's Dr. Butz here with the Fuller Butz Behind the Scene podcast of plastic surgery. We're back for season 2. Can you believe it, Sam?
Guess who's back? Guess who's back? Guess who's back? I live in Michigan, so I feel like I have to give a shout out to Eminem. Yeah, I was super excited when the admin let us know that we're renewed for a second season. You know, it was a little touch and go. We're almost one of those Netflix miniseries where huge following, you know, people are begging for it. We had to do it, right? We had to give more.
Right up there with Smartless, you know, competing, knocking on the door.
So is that what you've been doing with your free time? Not podcasting, has been checking out Netflix and chill, or what have you been up to over the summer and heading into this fall?
Yeah, you know, summer, just busy time. Work stayed relatively busy, a little slow down because everyone wants to be outside in the summer in Wisconsin, but also just taking advantage of that, spending lots of time with the family, lots of trips to boating, weekend, hang out with you guys at Mackinac. That was a pretty good trip.
Yeah.
NAPT meeting.
We both attended the Michigan Academy of Plastic Surgeons meeting in Mackinac Island in early August, which was a beautiful location. It was both of our first times that our kids were able to meet each other. So we had 6 rascals running around the restaurant and the island, checking out horse and carriages and pool. And we're fortunate to have beautiful weather. And it was really, I think, a great meeting. Was very low key, was able to get some updates on information for us to bring back to our patients. Dan, what was your take home points from the meeting?
Yeah, I thought it was a really well-run meeting, some great speakers. Good. It's always good connecting with other plastic surgeons, kind of picking each other's brains about, you know, how you might do things. Obviously, we didn't have time to do a podcast because we were chasing around 6 kids, but it was a really nice meeting, and, you know, great weather, good food, and company. So
yeah, I mean, you went on a
2-week
car trip through the UP and Wisconsin. So to lug all of your equipment for the podcast was probably not doable. Any other updates to your practice, your life that you want our viewers, listeners to be aware of?
Yeah, it's been a pretty crazy year in general. We opened up our surgery center, new building, a little over a year ago. So, you know, reflecting back on that, like, it's a ton of work, getting everything running smoothly and the team all in place. And now, you know, a year later, I feel like, you know, everything's kind of clicking just right. We have 2 new surgeons that have been around for close to a year now, and they've been getting busier, and you know, we're kind of getting close to that autopilot mode where everyone's just you know, cranking things out. So it's been a lot of work, a lot of time to, you know, get us here, but it's, you know, finally kind of at that place. Otherwise, yeah, practice has been good. Looking at starting to maybe do some research studies, kind of the sponsored study, which would be interesting. I can't really talk too much about those details yet, but an FDA study. And yeah,
good little tease there.
Expand. What about you? Yeah, someday we'll talk about it.
Maybe season 3, maybe.
Yeah.
So, yeah, it's been fun. You know, since we decided to do the Fuller Butz podcast, started following a lot more with Quintessa and your group and company in Milwaukee, and it's been really exciting to see the progress, the traditions, and, you know, different annual celebrations that you guys have. Seems like you guys are really processing and humming along there. We're doing great in South Bend, super busy practice, a couple of exciting updates. Recently had a research paper accepted into the Plastic and Reconstructive Surgery Global Open Access Journal. Yeah, so dropped
Big
that.
deal.
Yeah, it was exciting. We have at Southbound Orthopedics a research department, which is fairly unique for a private practice. So we actually have a full research director who's a PhD, Derek, who does a great job, phenomenal job of actually doing real research, real data, real number crunching. And then we have a grad student, typically it's a Notre Dame grad. In this case, last year, Connor Radigan, who was our Todd Graham Research Fellow, was looking for projects. I have a very strong interest in endoscopic carpal tunnel releases, and I'm one of the few surgeons in the country who do them in revision cases. And so just wanted to bring that back up to notice as far as in the research, because it's been since the early 2000s when that's actually been documented as a safe and viable option. Nothing's been said about it since 2007, 2008. And so if that's something that's in your practice and it's been almost 20 years since somebody's saying that, it's relatively refreshing rather than each month you're seeing the same topic talked about in so many ways. And so this was accepted. And it really demonstrated that it's safe to perform endoscopic carpal tunnel releases in revision cases where predominantly if they have had a previous carpal tunnel release, the traditional way is to do it open. And that usually means making an even bigger incision than before. Sometimes it means moving fat tissue around or doing fat flaps or even wrapping the nerves with synthetic nerve wraps to try to help things along, just because the success rate in revision cases are lower. So a lot of these patients who have recurrent carpal tunnel are older. Some of them have walkers. And so to really limit the morbidity with the lack of invasiveness with the incision is very helpful. So you're turning a significant incision across the palm and into the wrist into something that's just a few millimeters wide, 2 stitches, and a fast recovery where they can be bearing weight on it. And really, in looking at some of the numbers, which may be a second paper, it may actually be financially cheaper to do it endoscopically. And while it's new technology and equipment, by avoiding coding for a flap, by avoiding the synthetic wraps of a nerve, which can be thousands of dollars, and to avoid post-op recovery, the need for therapy, rehabilitation, these patients may be recovering faster and also in a more cost-effective way. So excited to bring that out to the table. As we mentioned in some of the hand podcasts last season, I have a patent for a flexor tendon device. I'm working really in sync with the Notre Dame Idea Center now to push that forward, to bring that to market. So we have some exciting upcoming meetings in the next couple months with some developers, some engineers, some designers to try to push that through. So those are some of my mini career hobbies and passions that pushing along. Otherwise still very busy in clinical practice with this hybrid hand, and even more so than last season, the plastic cosmetic side is really ramping up significantly, which is keeping me busy and excited. And one of the things that we have talked about really a lot over the summer, as we both seem to be increasing the frequency of using, is one of the kind of trendy things right now, which is an internal bra or an internal bra mesh. Isn't that right, Dan?
Yeah, I think it's been gaining in popularity. On these high usage surgeons are kind of promoting it, and I started using it a few years ago and kind of slowly increased the numbers that I kept seeing better and better results with it. It's a pretty powerful tool to help really improve the longevity of the results. What do you think kind of are the best patients for using an internal bra?
Yeah, I think even before I answer that, I would just throw it back to you and just to help our listeners out, like, what is an internal bra? Like when we're talking about internal bra or mesh or reinforcement, like what exactly is that? Because it's a bit misleading. And I feel like when you Google things and you look at the images or something, you're kind of looking at a bunch of random stuff. So can you break it down in simple terms, like how you address that or present it to patients in your consultation rooms?
Yeah, good point. For a long time, people referred to as internal bras during revision augmentations, where you're just kind of taking the old capsule and kind of tightening it up to create a bra, or kind of folding on itself, which is really just what we call a capsulorrhaphy. It wasn't really anything that special. When we're talking about an internal bra mesh, it's a mesh, synthetic mesh material. There are some cadaver-based ones as well that are very expensive and aren't routinely used. But this mesh kind of goes in under, well, there's different techniques to go to support the implant. The key things are that it fully goes away. So you're not left with kind of any permanent mesh in your body that could, in theory, have problems, but it creates longer and more strength to that capsule. Does that sum it up, you think? I missed anything?
No, I think that's great. And you had mentioned like who is a good candidate for that. And I think, at least in my practice, it is becoming more frequently used, or I'm having that light bulb go off just with this whole skinny shot trend, just with this weight loss trend. It seems like Americans more than ever are losing weight in a safe and sustainable way. And so I'm seeing a lot of patients who've lost significant weight. And as I'm evaluating them, I'm just seeing that their breast pocket, particularly their inframammary fold, is very loose. It's very elastic. And when I'm trying to set it and measure where the distance is, if that's something that's moving up and down or something that's a bit unclear, it provides me with rationale to discuss utilizing this internal mesh or reinforcement so that we can just better set the fold or give more predictable results, as opposed to, more likely than not, or, very commonly an excellent result, but every so often the implant sort of settles or drops a little bit lower than you want, and hemming and hawing, even though it looks good, it's, aesthetically pleasing, is it as perfect as we can make it? And so it's really just trying to minimize some doubt intraoperatively. And if we can really just provide more accurate and precise positioning of the implant of the pocket, that's where the internal mesh comes into. So for me, if you're grilling me and saying, hey, who's a candidate, I would say that, ultimately great candidates include patients who've lost weight or who have a poorly defined inframammary fold. That's more of a clinical judgment. But ultimately, there are patients who I would say that there's no one who isn't a candidate for an internal mesh or a surgical internal bra. And that's just because of what we talked about. If we can put the odds in our favor, make it more precise, and really give a predictable result for not an overly expensive item, I think that most patients are opting for that. And especially as the meshes have improved, I would say over time have become more integrated with the human body, have really enhanced rather than being something that was used, say, for a bladder reinforcement or for a hernia, and then you're throwing it up in the breast. These are truly being designed and utilized and made for the breast by breast companies. Any thoughts on that?
Yeah, I think you mentioned a lot of the key things. These meshes rapidly kind of incorporate and dissolve and slowly break down between 6 months and up to a year and a half. So it's kind of giving this long-term support while that capsule is initially forming. Yeah, I don't think anyone's really truly, not a candidate, but I think, the key ones are patients who lost a lot of weight, kind of stretchier skin. Some patients have really short, like nipple to fold distances, and we need to lower that and kind of recreating like called tuberous or constricted breast situations. We're almost creating a whole new crease. So I think it really is important for that. Implants add weight and volume. So that weight gravity is going to pull on it, stretch things. So the bigger the implants, the bigger the benefit of adding extra support. And then in particular, if you're going in the subfascial plane, where now you really are relying solely on skin and breast tissue in the lower pole, very common issue is that lower pole stretching, bottoming out of that skin over time. To really, again, reinforce that, I think is really important to provide a long-term result. And I think you mentioned, pricing. I'm not sure how you do it, but I charge a little bit more for the mesh, but nothing extra for the surgery itself. So like thinking about that technique, does it add a lot of time to your surgery, or how do you do it? That, when patients talk about like what to expect, is it different afterwards than just an augmentation?
Yeah, I'm exactly in your line of thinking, where I'm not paying for extra surgical time or charging for extra surgical time. I pay for the cost of delivery of the mesh to me to utilize. And what's nice about it, as I described to patients, it's essentially like suture. So we're using suture anyways. This is just a woven suture that gives predictable reinforcement at times when we know that there's stretch, when the body is replacing collagen and may become more loose or lax. And so we like to use that. To me, technically, it takes about the same amount of time as if I was reinforcing the inframammary fold with suture. We both have you sort of taught me, or I stole your inframammary fold suture technique as far as using a barb suture to try and reinforce that, which I think is a very strong and credible and reliable way to do that. There's lots of different ways to put the mesh in. One way that surgeons can do it is to simply not suture it in, to almost treat it like a taco, where you have the implant that's underneath the muscle or underneath the fascia, and you basically place the mesh underneath the implant, wrapped around the fold, the underneath of the breast, and then wrapped anterior to it. So it's just holding it up almost like a pita or like a taco, and they call it the taco technique. And then you close the soft tissue over it, because you're expecting and anticipating that mesh to stay there. It's not like it's floating in space. It's not like there's a whole lot of area for it to move around. And that's a technique that some surgeons use. To me, if I'm going to be, convincing my patients to use mesh, and I'm going to be wanting it to be used to reinforce the medial or cleavage line, the inferiormost portion, the lateral portion, I like to use a few sutures to really tack it where I want it to be. And this isn't a guesswork game. We use geometry, we use mathematical equations, we use, the radius and circumference, and we're really trying to place the implant and place the fold where we expect that to be in order to have the nipple center point and to have, beautiful symmetric breasts. And so for me, I like to place the sutures into the mesh down and tacking it to the presumed fold that has been calculated, has been created in the intraoperative period. And then, still using the no-touch Keller funnel technique, still irrigating it, still washing it with antibiotics, with betadine, placing it in, and then making sure and ensuring that mesh, while it's tacked down to the chest wall, is still wrapped and encasing that implant to provide that support over the 6 months to a year and a half to even up to 3 years before it's totally gone in certain mesh cases. So there's lots of different ways to place the mesh, whether you secure it or tack it down or not. Dan, if you're using internal bra and you're doing that in a breast augmentation or a breast lift, does that change your recovery? For the patients, are you telling them that they're going to recover or rehab differently, or do you use drains? Like, what changes in these cases?
Yeah, it's a common question patients ask, because it kind of sounds more invasive putting in this mesh, but really it's the exact same pocket creation. And then we just put the mesh down to reinforce that lower portion. So yeah, no drains, really nothing changes with the recovery. I like to tack it down as well. As much as there's not a lot of space for it to float around, like you're saying, I think having it secure exactly where I want it is important to me. But fortunately, the recovery is exactly the same. Early on, people often talk about, things looking a little square, frankenboobs we talked about last season. Sometimes that can slow it down a little bit. But ultimately it still does settle a touch. And I don't want them to look perfect at 3 weeks. I want them to look perfect at 3 and 6 months. So we want to slow down the stretching process as kind of part of the goal. And some people use implant bands on top. I use those kind of sparingly to help the process. If the skin's really tight, we need to kind of help stretch. But routinely, I really just let gravity kind of do its thing, and it again slowly gets into position. So I saw a patient the other day at 3 months. They're again looking quite good, but just nipples she did a lift at the same time, had lost a lot of weight. The implants were just a touch high into where everything. I was like, we're gonna just keep an eye on this. And I saw her at 6 months, and it's like everything, everything just settled. Not even a half a centimeter now. It's just all lined up exactly where you want it and kind of perfect. As perfect as things can be after surgery. So it is a process, but you want to, it's more, you're looking for the long-term result, not the 3-week result.
And in that patient you mentioned at 3 months to 6 months, did you did you encourage anything differently? Did you use the bands or have them massage or push the implants or just let nature take its course?
Yeah, I felt like it had made a big enough shift between, right after surgery to 3 months. It was like it was in the right spot. I didn't want to push it too much, so I let it kind of go.
Yeah, and just to reiterate, because you brought up a good point about the post-op Frankenboob, where things look a little bit distorted, a little bit elongated early on, and then there's this drop in fluff phenomenon. And overall, I think you captured it perfectly. We don't care how it looks at 2 weeks or 3 weeks post-op. We care about how it looks at 6 months and a year, and for the next 15 to 20 years. Do you change any of the timing as far as expectations of dropping and fluffing? Do what's the time range that you say things are going to start to settle out?
Yeah, I think it's still similar. It's just maybe a touch slower. So whereas maybe they were looking in a little better spot at 3 weeks, now it's more like 6 to 8 weeks before they're almost there. But I still want them kind of high and tight even at that point. So it's not dramatic, but it's subtle stuff, and everyone's a little bit different depending on the implant size, skin tightness. I think those things play a big role, more so than mesh or no mesh. What about you? Do you have any thoughts on that?
No, I feel like I've just been giving a little bit broader ranges. I used to, say like, oh, at, 6 weeks, we're really going to start to see this drop in fluff. And, it's just patient variability. Like you said, some patients may have a tighter fold. Some patients may have, lost a lot of weight and just have, some droop, and some patients' muscles are, just a little bit more stretchy and don't really behave as differently. So it's more of a matter of the first, few months, things are going to be changing. I like to see my patients frequently post-op just to ensure that things are okay, and really just to reassure them that, oh yeah, this is how it's supposed to look. This is how it's supposed to be. Make sure everything's healing appropriately. So during that period, it's fun and exciting because, they're happy, they're elated, immediately after surgery, but just to see how good things look over time is super exciting. And I do like to take some pictures between 6 weeks and 3 months and then 6 months, just because you can see that change where, as an Instagram social media person, as we all are, who want to put our results on. A lot of times, patience is a virtue as much as you want to post that 6 week picture. If you post a 3 month one, it looks even better in 6 months and a year later. And so you want to be patient as you're telling your patients to be. One interesting question that I've heard a couple of times is, as I'm showing them the sample, like I actually have mesh with my implants, sizers with them to show them, really have them hold it up. I'll even have the implants resting on this sample that I show patients, and show them how secure it can be, and then just kind of even show them on their own chest wall just how lax or loose their tissue is. Some of them have said, oh wow, this is great, that means I don't have to wear a bra ever again. This is great because it's all going to be internal. So how do you answer that question? Or for patients who are receiving an internal bra, does that mean they never have to wear a bra again, Dr. Butz?
Yeah, I do. I get that question a lot. Patients come in like, I don't want to ever wear a bra again, want the mesh, or then they want 600cc implants. And none of those things really go together all that well. And we're fighting gravity. The mesh is not bulletproof. So I really try to, especially early on, we want to get that capsule, that pocket kind of set. So I'm really a big kind of proponent of using bras for at least the first 3 to 6 months pretty much consistently. Some people can get away without it, but I think trying to have a standardized protocol, because if people just take them off at 6 weeks when they can start exercising again, they're just more prone to things stretching out a little bit more. So again, I try to just put as many guardrails on to try to get that result to last as long as possible. You can go braless for certain events, but most of the time trying to wear a bra is a key thing.
Yeah.
Do you have any other opinions on that?
No, I agree. For your patients who are breast lifts or breast augs without internal bra versus the ones with an internal bra, does that change how you recommend bra usage post-op?
No, the same protocol for everybody. Yeah, again, it's the same. We're just trying to, guide you to get you the best result. I don't think that the internal bra provides extra support, but it does not, it's not bulletproof. It's kind of how I like to think about it. So we're trying to help it along.
Okay. And then, just another question that we get asked, but something that's important that we bring up, even, if it's not asked, is just the risks, the risks associated with something different, something that's not their own tissue. And this internal bra mesh certainly has to have some risks associated with that. What do you tell your patients, or what are we going to tell our listeners on the Fuller Butz podcast to, be concerned about, or just to be aware of?
Yeah, 100%. It's really important to be aware of, the pros and the potential cons. Fortunately, there's been a lot of studies looking at these meshes, and they have been shown to be very safe. I think the key thing, a lot of patients, when you first mention mesh, they think of, late night commercials talking about, infected hernia meshes, bladder meshes.
You might be entitled to a class action lawsuit.
Right, exactly. So the great thing about these meshes, they're not permanent. So again, they quickly incorporate into your tissue, and your body breaks them down. So infection rates are less than 1% in pretty much all the studies. There's some data showing that they might help resist against capsular contraction. So that hasn't been totally fleshed out yet, but there's newer studies looking into that. The biggest thing I think that the patient be aware of is there might be some palpability of the mesh in those first year and a half. Depending on the mesh, how thick it is, how strong it is, you might be able to kind of feel some the ridges essentially of it in that wherever it's placed. And this is the same sometimes with their sutures, but it does go away. This again, it just takes time. So as long as they're prepared for it, normally I haven't had anyone complain about it. And the softer ones I've been using more of lately have much less of that.
Yeah, I agree. I think you've summarized that well. To me, I don't consider this to be a permanent device or an implant. It's dissolvable, and it's nice that it's similar to suture. So I'm essentially, telling patients I'm using the same type of suture to secure it down to your chest wall as the meshes itself. And so just as we would expect the sutures that we're using to dissolve and go away, sometimes they can be palpable. The same is true with the mesh. I'm very risk adverse, as we all are, particularly with breast augmentations. And so I'm still pretty meticulous with using copious antibiotic irrigation with the dilute betadine with minimal, touch technique. I do feel like just in setting the mesh, because we're using such a small incision in the fold, after we place the funnel, that I still need to make sure that mesh is, covering over where we want it to be. And so that does, sometimes require a little bit more manipulation than what I, typically do without the mesh. A lot of times I'll use, the back of one of our surgical instruments that's been dipped in the betadine, and just use that to, smoothen over that, almost like you're placing, cream cheese on a bagel with just a very dull butter knife, where you're just basically coaxing it so that it's less lumpy, and then it's exactly where you want it to be. To me, I don't think that increases the risks, but it's just, as far as the technical details of the procedure, it's a little bit more insurement at the end of that placement period, but still something that is well worth the benefits. Certainly exceed any sort of minor additional securement or reassurances that the mesh is in the right spot.
Yeah, it's definitely important to get it smoothed out. So you have to do something after the implant goes in. They do the same thing. Everything's dipped in betadine. Normally it's an Army Navy and a back of a forceps to kind of help smooth and make sure it's right where I want it. Then tying it down with my parachute sutures so no needles get close to the implant. It's pretty much, again, just as fast and just as smooth as any other. The
studies that you referenced as far as potentially being used in breast reconstruction and patients after breast cancer, I think is particularly exciting or enlightening, in that those are higher risk cases with more problems. And if we are transitioning away from what we typically use, which is acellular dermal matrix or cadaver dermis, which is very expensive, can have risk associated with not so much rejection, but just fluid buildup for the body not incorporating it as well as you would like, to see really, potentially some really good results where the mesh is used, which is more breathable, which is more cost effective, easier to handle, and to not have exceedingly higher risk associated with that. Or maybe some literature that actually supports that placing this mesh in really helps to prevent your body from overcompensating by forming a more firm capsular or capsular contracture. Can actually be, even more benefits than what we're telling our patients. I'm not necessarily guaranteeing that because I think it still needs to be borne out in the literature, but potentially a lot of excitement and enthusiasm for these internal bras as we're recommending them or discussing them more thoroughly with our patients, as time has gone on.
Yeah, I think it's an exciting new modality and more modern kind of breast augmentation. And again, with breast lifts and reductions as well, I often incorporate them to try to help really minimize gravity, again, pulling. But that's used in a little bit different way and less of, less concerns about the implant and another foreign object. But yeah, I think they're a great tool. And I used to kind of just mention it to certain patients. Now I feel like I just have to tell everybody because some people are like, oh, I definitely need that. Others are more like, well, you decide, and I try to, can make it. I want them to be choosing, but giving them the pros and cons, and going back to sometimes what I would do for a family member. I think now it's definitely, I'm more in favor of using it than not, unless there's a really good reason not to, or a really small implant, or different things. So
yeah, for sure. I think it's important just quickly summarize a couple points for each of us. Our thoughts on the internal bra. For me, it is not prohibitively expensive. I think that the cost of this synthetic, reabsorbable, dissolvable mesh that's used to reinforce the breast fold to really keep that pocket where we want it to be, to give more predictable results. With very low risk, as it's essentially just suture material, has many advantages. It's a very trendy thing, and we thought we would start off season 2 by discussing it in more detail, just because you hear about an internal bra, you have a friend who got an internal bra, and it just sort of gets lost in the communication. So we just wanted to hammer down some finer points with that. What are your couple take-home points for our listeners in regards to the internal bra?
Yeah, I think it's very safe and provides you with that better longevity. I don't think you should do something because it's trendy. I think you should have, it is becoming trendy, but that's because there's more and more science behind it and better kind of long-term results showing its true efficacy. So, I think that's, 6 years ago when it was first being used, I was like, I'm going to, sit and watch this and see what happens. I wanted to, obviously be informed about it, and then, starting to use it and testing it on kind of select patients who were perfect candidates, and then kind of expanding as I continue to see better and better outcomes. So, I think it's an exciting tool, and it's
same
just
recovery,
all about being informed, right?
Yeah, and I think just as both of us have pushed for the drainless tummy tuck, kind of watched it, made sure, we don't want to be experimenting on our patients. We want to be offering them something that's not gimmicky, where the next year we're going to be saying, oh gosh, this is a recall, we're going to be taking all that stuff out. This is something that's tried and true. It's not novel by any stretch. It's been around, and now we just have the evidence to really push it, the success and the predictability and the benefits of it to our patients.
Right. So I think, season 2 kickoff here. We got an exciting season ahead of us. I think we're going to try to bring in more guests. We really appreciate if, patients or listeners have questions, they can hit us up. We're happy to kind of address those. We could maybe do a live Instagram sometime and hit up, live questions. So we're trying to expand this, kind of see where it goes, but working on, going into fields that are areas that we don't really do a lot of, facial, more breast reconstruction, which we did a lot of historically, but bringing in some really experts in the field in these different areas that can give us more info. Yeah,
biohacking, nutrition, spa,
fillers,
med spa content. So lots of great content, exciting new topics. We'll hit up some hot topics. Maybe we'll dive into salmon sperm and other trendy things that are going on and get the real truths to them. We're excited to push even further with the guests and some surprise guests. So lots in store for season 2. We're excited to be back and appreciate you listening. Always great to see you, Dan, and have a good rest of the week for you.
Yeah, we'll talk soon. Later.
All right. See ya.
Thanks so much much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @SFullerSurgeryMD or @DanielButzMD. That's Butz with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.